And welcome everyone to the March workshop for PFCC partners, community members. We are very excited this month to have Michelle Johnston-Fleece from the National Academy of Medicine, along with our very own Libby Hoy, the founder and CEO of PFCC Partners, to present the National Academy of Medicine's guiding framework to person-family engaged care. Before we move on to Michelle and Libby, I just wanted to update you on Zoom. If you haven't used Zoom before, you should see my screen in front of you. If you hover over the bottom, you can find your mute button, and then you can also find the chat box as well, where you can ask questions throughout, start some conversations. I put a little introduction in there. Oh, we can't hear you. Can you hear me a little bit better now?
Yep, I'm hearing you well.
Okay.
Yep.
Thank you. Sorry about that. If you wouldn't mind, while we get started here, to introduce yourself, tell us where you're located, and then throughout, if you have questions, go ahead and add them to the chat box, and we'll have some opportunities too for everyone to come off mute and ask questions and have some conversations as well. Okay. And of course, my phone's ringing. Sorry about that. As we get started, first, I'm just gonna hold on just a second before we go into our mission. So please give me just a minute. Okay, sorry about that. I just want to check in and make sure everyone can hear me. Can you still hear me?
Yes.
Okay.
Yeah.
Okay, good. That was my call. Someone was telling me they couldn't hear me. Anyways, if you are new to PFCC Partners workshops, our mission is really to partner with healthcare organizations and the public to provide a collaborative learning community, which is what we're doing here, and why we have Michelle with us today to talk to you about the guiding framework. We're really excited about sharing those proven methods, successes, and challenges that will help to guide the development of sustainable patient-family engagement structures across the healthcare continuum and with the organizations that you're at or that you might be partnering with. So with that, I'm very excited to welcome Michelle Johnston-Fleece, who is the Senior Program Officer at the National Academy of Medicine, and Libby Hoy, founder and CEO of PFCC Partners, and also a Scientific Advisory Council member for the National Academy of Medicine. Michelle?
Thank you, Lindsay. I appreciate that, and I'm very pleased to be here today to talk with you about some of our work in patient and family engaged care. I have to say, on a personal note, I come to this work as a person who had a personal experience as a family caregiver, and actually came into this field after that experience. So it's extremely gratifying for me to be with this group and also to be involved in this work at the NAM. What I thought I would do would just start by, Lindsay, if you can do the next slide. Wanted to start by giving you a little context on the National Academy of Medicine itself and the role we play in healthcare and in the United States. So as by way of background, our umbrella organization is the National Academy of Sciences, and that was actually established back in 1863 by an act of Congress, which was signed by President Abraham Lincoln. We are created as a private non-governmental institution to provide independent, unbiased advice to the nation on issues related to science and technology. In terms of the way we work, we have staff, of course, but primarily our work is driven by our members who are elected by their peers for their outstanding contributions to the field, in particular in research, and they act as volunteers in their work with us. Next slide. In 1970, the Institute of Medicine was founded within the National Academy of Sciences, specifically to advise the nation on healthcare issues and to improve the health of people everywhere. The way the IOM worked was to convene preeminent experts in the field and produce what we call consensus reports. These reports involved convening all the experts in a particular area, reviewing the literature on the topic, and then publishing the scientific consensus on policy recommendations for a given area. To give you a sense of our reputation in the field, the New York Times described the IOM as the most esteemed and authoritative advisor on issues of health and medicine, and its reports can transform medical thinking around the world. In 2015, we had a bit of a reorganization of the way just we're organized internally, and the Institute of Medicine became known as the National Academy of Medicine, or NAM. And our mission at the NAM is to improve health for all by advancing knowledge and accelerating progress in science, medicine, policy, and health equity. Next slide. You can see here some of the important influential consensus reports that were developed by the IOM. Some of them you may have heard of, such as the Crossing the Quality Chasm report, which was released in 2001. It's well known for including patient-centeredness as a crucial component of a high-quality healthcare system. After the organizational change in our name to the NAM, our consensus reports are now branded and come out as products of the National Academies of Sciences, Engineering, and Medicine. And NAM works more broadly through both domestic and global initiatives to build on the work of the IOM and address critical and emerging issues in health, medicine, and related policy, and inspire positive action across the field. We still collaborate closely with our peer academies, particularly the Health and Medicine Division of the academies, which continues to produce consensus reports. Next slide. In terms of our programs, the NAM administers fellowships, scholarships, and awards. We host workshops, expert meetings, and symposia, and we conduct programs to enrich the broader work of the academies. We also publish perspectives and expert commentary and discussion paper series. This slide actually shows you all the current initiatives that are happening within the National Academy of Medicine. And I want to point your attention particularly to the Leadership Consortium for a Value and Science-Driven Health System, which is where the work we'll describe today was generated. The Leadership Consortium is comprised of national leaders and innovators from all of the major healthcare sectors and stakeholder organizations. The members of the consortium share a common commitment to transforming healthcare through achieving a health system that is continuously learning and improving, and thereby increasing the effectiveness and value of healthcare. Next slide. The Leadership Consortium works through the activities of its member organizations, but also through the work of our 4 innovation collaboratives and 2 leadership networks. Each innovation collaborative is devoted to developing collaborative projects that drive progress on the areas we see as most important for advancing science and value in health and healthcare. These are, as you can see on the slide, value incentives and systems, clinical effectiveness research, digital learning, and care culture and decision making. You'll also see our 2 leadership networks, the Patient and Family Leadership Network and the Executive Leadership Network. I'll talk a bit more about them later, but I want to note that the work we're presenting today emanated out of the Care Culture and Decision Making Innovation Collaborative, or as we call it for short, the CCDMIC, and involved members of the Patient and Family Leadership Network. To give you a little information on the CCDMIC, we bring together patients, families, clinicians, technology and communications professionals in order to promote patient and family-centered care. And by that, we include both team-based healthcare and shared decision-making. The collaborative is co-chaired by Mary Naylor, who works out of the University of Pennsylvania, and Bill Novelli, who's a former CEO of AARP, and is now a professor at Georgetown University and the co-chair of the Coalition to Transform Advanced Care. The goal of the CCDMIC is to spur joint activities and drive healthcare culture in 3 main areas. One of those is culture. In other words, to ensure that the next generation of clinicians provides care that reflects patients' preferences and values, that care teams work collaboratively and in concert with patients, and that healthcare leadership fosters the creation of a culture of care that is seamless and team-driven, where importantly, patients and families are integral members of the care team. The second area we work is in evidence. The ability to make informed decisions really requires that timely delivery of scientific evidence gets to patients and families in a format that best meets their needs to help inform their healthcare decisions. And the third area of focus is engagement. As awareness and opportunity has grown for patients and families to be more engaged in their own care, as well as in the design and delivery of healthcare at the organizational and policy levels, we think it's critical to engage all healthcare stakeholders to guide the transformation to a patient and family engaged care culture within systems that continuously learn. Central to this activity is the ability of patients and families to play an active role in healthcare decision making. Next slide. You'll see here all the collaborative activities through which NAM's innovation collaboratives may accomplish their goals. The particular activity that we're presenting today was produced as a discussion paper or white paper. NAM discussion papers are expert commentaries by leading voices in health and healthcare. That is, they present the opinions of the authors on key topics in health and healthcare. Next slide. So getting specifically into the work we're here to present today. The work first began as a convening or bringing together the key experts in the field. Over the years, the CCDMIC discussions highlighted great interest in the field for gathering and synthesizing the evidence base for patient and family-centered care and patient and family engagement. It was known that a lot of work had been done and that there was a building evidence base, but no one had yet sort of pulled that together and organized it. So in response, the NAM convened a scientific advisory panel of 25 experts to identify the elements and factors that consistently emerge as essential to creating and maintaining a culture of patient and family engaged care, organize those tools, strategies, and cultural elements into an easy-to-follow framework, compile the evidence in support of the framework, and identify gaps and opportunities to guide culture change strategies. Next slide. This is a list of all the members of the scientific advisory panel on the evidence base for patient and family engaged care. As Lindsay mentioned, Libby Hoy served on that panel. The panelists included clinical and health services researchers, healthcare practitioners, and patient and family leaders. Importantly, outreach efforts for panels extended beyond what are considered the usual suspects. Certainly not to devalue the important insights of the familiar faces who have been really working in this field for a long time and advocating for patient and family-centered care for years, but rather to make room at the table for a growing group of researchers and other leaders who are studying the impact of the often overlooked dimensions of patient and family-centered care, and whose work, when accumulated and synthesized, really helps advance not only the scientifically based case for patient and family-centered care, but also what we term the experience base. That is, what we're learning from those who are doing the hard work in the field every day that may not be part of a formal scientific study. Next slide. This slide provides an overview of the way the panel conducted its work. Conference calls were held over a 6-month period, during which a number of case studies were presented by healthcare leadership from various settings, including an acute care hospital, a behavioral health hospital, and a federally qualified community health center. The case studies helped the group identify core elements and patterns for creating and sustaining a culture of patient and family engaged care. There were then a series of presentations of evidence that relates to these core elements, and the group began to organize that evidence into a framework, identifying where there were gaps as the discussion progressed. Next slide. To guide the discussions, all the panel members were asked to consider these questions. So first, what common elements emerged from the presented case studies as important drivers for creating and sustaining a culture of patient and family engaged care and meaningful engagement? The group was then asked to reflect on their own experience and consider how the case studies align with their understanding of culture change and patient and family engaged care. Specifically, how do the case studies support what you found in your research or your experience? And based on your research or experience, what key pieces were missing from these case studies? And finally, what are the key areas of opportunity to build on the evidence and experience base for patient and family engaged care? Next slide. This slide is really a shorthand of how the field has progressed over many years. As I mentioned earlier, the Crossing the Quality Chasm report in 2001 defined patient and family-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Though this wasn't the first mention of patient and family-centered care, this definition was seminal in raising the profile of patient-centeredness as a central attribute of high-quality healthcare. Over the years, extraordinary work has been done to realize patient and family-centered care, and in order to do so, patients and families have increasingly engaged on healthcare improvement work. As a result, patient and family-centered care and patient and family engagement today both embrace partnership, working with patients and families, not simply doing to or for them. The panelists recognize this as a fundamental shift in the way we work in healthcare. And to recognize that shift, coined the term patient and family engaged care, or PFEC. And they defined PFEC as care planned, delivered, managed, and continuously improved in active partnership with patients and their families, or care partners as defined by the patient, to ensure the integration of their health and healthcare goals, preferences, and values. It includes explicit and partnered determination of goals and care options, and it requires ongoing assessment of the care match with patient goals. I'll now hand it over to Libby Hoy, who may have more to add here, and will present the guiding framework that resulted from the panel's work.
Thank you so much, Michelle, and thank you for joining us today with our community to share this really important piece of work that I was very proud to work on with the National Academy of Medicine and with this scientific advisory panel. And I have to say the panel was a great representation, a broad representation across the healthcare continuum of all stakeholders, including patients and families, myself included, as well as others. And I really appreciate the National Academy of Medicine leading the way with walking the walk as much as you're talking the talk about engaging patients and families at all levels of your organization and in the co-creation of these important pieces of evidence and the framework. Next slide, please, Lindsay. So here on the screen is what the Scientific Advisory Panel came up with, the Patient and Family Engaged Care, a guiding framework. I really am excited about this piece of work because for me, having worked in engaging patients and families meaningfully across the healthcare continuum, whether that be in the clinical relationship all the way up to co-creation and co-design of healthcare systems delivery, research, and even broader into policy. Having worked in that area for so long, there was always a sort of a lack of this comprehensive and yet concrete framework to get to the culture shift. And I really, this has resonated with me so much and with the organizations that PFCC Partners works with to engage patients and families, again, across the healthcare continuum. The comprehensiveness of the framework, I think, is one of its strongest benefits. Another benefit is the fact that it's not a linear framework, right? You don't start at the right and get to the left and there you go. And as all of you who are working so hard to infuse patient-family engagement across your organization, you know nothing's linear, right? And so the framework provides some flexibility. And you can see if you have very strong leadership commitment, maybe you've already started some fantastic engagement opportunities like bedside rounding or other programs. And so you may not need to start necessarily at the organizational foundations and looking at leadership and looking for your levers of change. You may be able to move into more of the skills and awareness building and getting into staff education around what does patient-family engagement look like, and how do we create that culture in our organizations that supports patients and families to get engaged. So I would encourage you, as you're thinking about your own organizations and looking at the framework, to sort of recognize the things that you have accomplished and have worked on, and where does that fit in? Does that provide you more structure to build on in your organization? Or maybe do you need to go back and implement a patient-family advisory council if you haven't, or another structure for bringing patients and families into your organizations? What does shared governance look like in your organization, and how does that get expressed? So again, I would encourage you, with your own organization in mind, to really look at where are you, and if you've implemented a number of the practices under the strategic inputs, are you getting those practice outputs that we would expect? Are you getting an increase in family presence and activation? Are you getting improved care coordination with patients and families being engaged? Is there a benefit in that area? And then finally, once the engagement is really hardwired into the culture of your organization, are you getting those outcomes, those engagement outcomes, which are the quadruple aim? So the comprehensiveness, the impact to culture, and the culture shift to an engaged care organization, and then the flexibility, I think, in finding where you are right now. So not everybody starts at the same starting point. We know that. So how do you just identify where your organization is within the framework and kind of move through it from there? Next slide, please. I really appreciate it, and I have to tell you personally, I struggled with a little bit of the monitoring and the data collection, and I'm a patient-family advisor by background, so I'm passionate about this stuff. I know that it's important. I know that it has a positive impact on outcomes, because it certainly did for ours. So I didn't always understand the value of the gray loop that you see on the outside, the monitoring, the data collection, and continuous feedback. But I do understand now, and I think this is really important. It was an important part of my learning journey to understand and embrace the fact that healthcare improvement happens on data. We need numbers, and we need to understand where we've been in order to understand how to build on that success. And so what I have always known about this work is that we don't get to a endpoint of person-family engaged care and check that box and there we go, we're done. It's a continuous loop. We're going to continually change in healthcare. It's the most dynamic industry in the world, right? We have new medications, we have new protocols, we have new research educating us all the time. So it's going to be a continuous growth journey. I want to point out too, in some of the core elements here on the leadership. I think we've all talked so much about how important it is to have leadership on board with these efforts, and it is critical. I just want to speak to, for a moment, the importance of what that leadership support looks like. So it really needs to be activated. The leadership needs to be engaged in an assessment of current state that is realistic, that's of value. Leadership needs to acknowledge and recognize some of those change champions and bring in others that can support this work. So we're talking really about it's an organizational foundation to have leadership on board, but that leadership really needs to be activated. Next slide, please. Thank you. So this again is a deeper dive into thinking about some of the activities that you have going on in your organization, where you have made efforts and where you might target future efforts. Many of you on the call today are participating in programs such as the Transforming Clinical Practice Initiative in the ambulatory setting, and the Hospital Innovation Improvement Networks, or the Quality Improvement Networks, the Quality Improvement Organization Networks, I should say, the QIOs. you have within those CMS mandates for patient-family engagement or person-family engagement. This framework can really help you to actualize those in a way that takes the metrics that you're being asked to report on and builds the culture around that. So that we're not doing these in isolated, we're not embracing patient-family engaged care in an isolated effort, but rather we're really shifting the culture of our organizations, which allows us to meet those metrics, right? Instead of working to the test, so to speak, we're really shifting the culture and improving the number one, the better culture, right? So for our staff members as well as our patients and family members, but better care, better health, and lower cost. We're getting there. So the framework really provides a framework for moving forward in the work that you're already doing. So this isn't something necessarily new. And again, I just encourage you to do an assessment of your organization, really take a look at where you've gotten some wins and look into this framework to where you can move forward with those efforts. But it's relevant across the current efforts that you're making. Next slide, please. There was a subset of the members of the scientific advisory panel that took the charge to present the framework and associated evidence. This paper was published in January 31st, 2017 as the NAM Perspectives discussion paper. And the discussion paper is a deeper dive into the logic and evolution of the framework with more connections to the healthcare environment. I think what was really a great learning journey for me in co-authoring this discussion paper was the opportunity to look at the framework from all the different perspectives that were represented on the scientific advisory panel, or at least most of them, and to describe in greater detail how the framework could be implemented or could be used in an environment to implement person-family engaged culture. And so it kind of breaks down all those pieces into the logic behind it and how organizations or individuals may move this forward at that organization. Next slide, please. So for those of us who've been working on a long time in this area, the compendium was a great effort at kind of pulling together all of the research and evidence and for person-family engaged care or patient-family centered care. And this is a next iteration of that is so well organized and easy to use. So for instance, if you're struggling with some of that leadership and you need some evidence to back up why you need to do this work or why you need to proceed on an assessment of current state, you can find research articles to take forward. So you have that evidence base to take forward to your leadership to empower them and to move forward in this. Same with every component of the framework, which I think is just an amazing resource. It just creates that backup, if you will, especially for those of us as patient-family advisors trying to move this work forward in organizations. Sometimes we need a little bit more backup, a little bit more credible evidence, and so this is just such an easy way to use it and really gets to every component of the culture shift to person-family engaged care. Next slide, please. Some of the patient-family advisor roles, and I know a lot of you will be familiar with these, you'll be using advisors on there, were identified as well in the discussion paper. The opportunity here is to really expand all of our thinking on the multiple opportunities for patients and families to partner with us in co-design, in true co-design of our healthcare system. So starting with members of patient-family partnership councils or advisory councils, rapid improvement teams, any of you out there who are engaging advisors onto your lean efforts, full standing committee members on safety, facility design, planning, implementing, all across the board, including research, including policy programs or efforts. Members of groups creating and implementing, evaluating health information and resources. Family faculty infusing patient family advisors into employee orientation and giving that first opportunity to our staff members to connect and to learn from and learn with patients and families. Patients and families are partnering in research across the board with the wonderful efforts of PCORI and others that are now seeing the value of engaging patients and families into research. Members of root cause analysis teams and appointed members of the system's governing bodies. We know, those of us who are working in hospital innovation and improvement networks know that that's one of the 5 metrics, right? One of the 5 PFE metrics that you'll be reporting on. Do you have a patient family member on your governing body? That's not to say that one or even the root cause analysis team. That's not to say that that's going to be a starting point for your advisory efforts, but it's something that can be intentionally moved toward. And that's the goal here, is to really expand your thinking of the value of the partnership with patients and families and how far that can go, how many, many places that can be implemented with intentional preparation and movement towards that goal. And I will say that preparation of your advisors to move into some of those more advanced sort of opportunities is critical to their impact. We as advisors need context. We need understanding of the goals and objectives for a team, just very much like the National Academy of Medicine gave to me to enable me to participate effectively on the scientific advisory panel. I needed background information, what we were doing, what was the purpose, all of those things. So that level of preparation for your advisors onboarding into these roles is critically important for their impact and sustainability. Next slide, please. Examples from the field. These are packed into the discussion paper, and I really encourage you to take a look at them and see how they can be adapted at your organization. I think this is, one of the requests we get at PFCC Partners daily almost. I just finished an email responding to a request for what's going on out there, who's doing the orientation piece really well, who's doing bedside rounding really well, and how can we connect to those. So there's some really high quality examples from the field included in the discussion paper that I think, not every organization is the same. However, you can take, sort of those nuggets of knowledge and apply them within your own environment and make that change really locally. Next slide, please. To go along with the examples and to support your efforts in this way, there's also a number of wonderful tools included in the discussion paper. It supports to support the engagement at all levels. Both the tools in the example section are intended to be dynamic in nature, which is fantastic. So it'll be added to over time. And what a resource that will be. And I just would challenge and ask all of you, what will be your contribution? When you take this framework back to your organization and you start to build out this culture, bring it back, share it with the field, spread it so that we get this in every organization across the country. I think I'm turning it back to Michelle here for the next slide.
Thanks so much, Libby.
Sure.
So I wanted to follow on with some of the opportunities that were identified in the discussion paper. These are some of the gaps that were identified by the scientific advisory panel and suggestions for ways in which the field may be advanced by broader collaborative activity. So quickly, the group thought that, broadening the accepted definitions of patient and family engagement and patient and family engaged care are in order in terms of, again, applying this concept of patient and family engagement really throughout all aspects of healthcare and healthcare delivery all the way throughout the continuum. the one thing that the panel came up against frequently was the limitations of our traditional ways of rating the quality of research. The way this work is done and really where success is reached is not always very measurable in a randomized controlled trial. When journals publish papers, they rate, the quality of the research, and that is more often those scales are tipped toward randomized control trials and some of these more traditional trials that we see in health and medicine. We think there's an opportunity to elevate the credibility of experience-based research and qualitative research that align with the priorities and experiences of patients and families. A really important point is the need for greater inclusion and the proactive engagement of underserved, hard to reach, and quote, complex patients and their care partners. There is a lot of evidence and an emerging evidence base around really the value and impact of patient, family, and community engagement. There is less evidence in the proven methods of engaging some of these other communities effectively and the impact. Another area was in terms of aligning patient and family engaged care across program standards and measures. As we all know, as patient and family centered care and patient and family engagement have really been successful at infusing throughout healthcare, we have seen regulatory bodies and standard setting organizations requiring patient and family involvement, which in addition to many other requirements that hospitals and health systems face, kind of leads to sort of confusion in the field around what are the priorities, what really works. So we think that there's a real opportunity for greater alignment across these standards and measures to really help us all move in the same direction to advance the work. And finally, the group saw an opportunity for further exploration of the opportunities to strengthen and expand the evidence base, focused on, for example, the effectiveness of training to expand the capabilities of patients and families in partnering, the effectiveness of patient engagement in large-scale quality improvement efforts, that is the relationship between outcomes and the degree of patient and family co-design, and the extent to which experiential learning creates sustained changes in the behavior of healthcare team members. Experiential learning is one of the areas in the framework, and we'd like to see more evidence developed in how that really can create a sustained change in culture. Next slide. We've been really excited about the reception of the framework has received in the field and as well in the press. Just as one example, Forbes Online published a discussion among health system CEOs about patient engagement. And central to that article was the guiding framework. Next slide. In addition, the British Medical Journal has published an editorial on the discussion paper and the framework. I'm really calling it potentially seminal work. And again, we will be actually reaching out. We will be speaking with the co-authors of that editorial to really speak with them about how we may work with them as well and get their thinking in advancing the field. Which brings me to the next slide. In terms of how the audience on the webinar today can really help us build on this work, we'd really love your engagement and involvement. And as Libby indicated, we'd love you to share the paper, the annotated bibliography of evidence, and utilize it within where you are working in your institutions and the institutions you work with, to utilize and share the tools that are cited in the paper. Partner depending what role you play, partnering with patients and families, or partnering if you're a patient or family member, partnering with health system and clinical leadership to share and implement the framework. We'd really love feedback on the framework. As Libby indicated, we see this as a dynamic work. This is the beginning. This was to begin to organize the evidence, and we will continue to follow the work. We'd love to hear your feedback on the framework. We'd love to hear any more additional scientific and experience-based evidence that you'd like added, or just your feedback and how it's working as you work to implement it out in the field. We also would really particularly appreciate ideas for collateral materials or messages to encourage the implementation of the framework among both patient and family leaders, health system executives, clinicians, and other key healthcare stakeholders. We realize that not everyone will or wants to read a 40-page discussion paper, and that there are really opportunities to boil down the key messages to relevant groups that really are key and instrumental in shifting culture at in health systems. And we'd really love your ideas on how we might do that effectively. And you can also engage on other collaborative activities emanating out of the NAM as well as in the field. Next slide. In terms of the NAM, as I said, we'd love for you to work with us. One way to do that is by joining the Patient and Family Leadership Network. The network, it's a virtual network that engages patient and family thought leaders as advisors to the NAM and to others to achieve better culture, better care, better value, and better health for all. In the past, the Patient and Family Leadership Network was focused on involving leaders of hospital, patient, and family advisory councils. But over time and a lot of discussion with patient and family leaders, we've expanded the breadth of the network to include patient and family thought leaders throughout the continuum of healthcare, from the individual and hospital level up through state and federal policy levels. So wherever you're working to transform healthcare, we'd like your participation in the Patient and Family Leadership Network. So we're actively expanding the network and really encourage you to sign up by visiting the website. The URL is there at nam.edu/PFLN. And knowing this is a mixed audience, next slide, we also, recognizing the key role of leadership among healthcare executives in changing culture, the NAM formed the Executive Leadership Network, or ELN. The ELN is a network of health system CEOs and aims to strengthen their communication and collaboration so that among executives that share our common interests in driving a culture of continuous learning and improvement within and across healthcare delivery systems. If you're a senior leader of a health system, we'd love your participation in the ELN, and you can get more information at the website there as well. And finally, as Libby mentioned earlier, the Resource Compendium for Patient and Family Healthcare Leadership. The compendium was a publication that was produced in 2015 by members of the Patient and Family Leadership Network when it was first pulled together. It was intended to gather the resources and evidence on the impact of patient and family advisors. And really, this work led to the development of the Scientific Advisory Panel and the guiding framework. We will be updating the resource compendium this year and welcome your thoughts, suggestions, and involvement as we do that. We think the guiding framework really provides a nice organizing principle for the information that's in the compendium and really gave us a good head start in the update to the compendium. But we'd like this to be an evolving document as the field evolves and develops and more evidence comes out. So I welcome you to contact me if you're interested in being involved in that work. Next slide. And I think that wraps up our presentation. And we'd love to, have a discussion and answer any questions you may have. And as a prompt to the discussion, we put a few questions up there that were what I mentioned earlier in terms of what you may have as suggestions for ways of best communicating to key audiences about the framework, and in your experience, what the most compelling messages are to these audience. How can we most effectively communicate the key messages to really drive forward patient and family engaged care? So with that, I guess I'll turn it over to Lindsay for the Q&A.
Thank you, Michelle, and that was fantastic. It's so great to see so much detail about the guiding framework, and thank you for sharing that with us. If you do have any questions for Michelle or Libby, you can speak up now or go ahead and post them in the chat, and I will manage that. First, we have a question from Mary at Sutter Health. She asks, how do you envision measuring culture shifts, as she found researchers resisting including patient partners in data analysis phase of research due to lack of training? They are making some inroads to change perceptions on our ability to add value. So I guess the question there is, how do you envision measuring those culture shifts?
This is Michelle. I can take a stab at that. I feel pretty well positioned to talk a bit about this because actually prior to joining the NAM, I worked at PCORI, where I was an engagement officer. So my role was to help researchers and research teams, including patient and family advisors, to help them work together in all phases of the research studies. So, Mary, you're absolutely right that it can sometimes be challenging on both sides, on this, particularly in the data analysis side, during the study and how to involve. I think that's where we identified in the paper some of the gaps as being around training. Both for, and we see that not just as patient and family advisors being trained to operate the way into a healthcare system, but it's also about researchers as well as health system leaders, clinicians being trained how to effectively engage as well with patient and family leaders. In terms of measuring, I think that's a really good question, and I think that field is still evolving. I think, again, this is where PCORI is instrumental in this, particularly on the research side. You know, they are evaluating and collecting data from all their research projects. And so they get annual engagement surveys that go out to the partners in the research, the patients, families, and other stakeholders partnering in research, as well as the research teams, to gather feedback and data on engagement. And they release those findings through a number of means, including, you know, published papers, but as well as webinars and other means. And I think that will continue to evolve. I think, again, there's great potential in sort of qualitative study to really understand how this is done. What are the successful methods of engaging patients and families where a qualitative analysis, or excuse me, a quantitative analysis might not be able to get at some of these finer cultural elements and tracking those culture shifts.
Great.
Yeah, and this is Libby. I will defer to Michelle's expertise and just say again how grateful I am for PCORI in making space for patients and families in all of this. I think it's going to be a challenge to measure culture shift. It's difficult to measure something so sort of fluid and dynamic in nature. So I think much more on that to come. But as far as looking to examples of how patients and families are being engaged across all areas of research, I would definitely look to the examples and those of us who are working in PCORI projects.
Great. Thank you both. And we have another question in the chat box from Morgan Horwood. She says, you mentioned CMS mandates for person and family engagement. Can you expand on that? Sure.
So this is Libby. Michelle, I can go ahead and take a stab, and then if you'd like to chime in. Yeah, so what I was referring to, Morgan, is CMS came out in December 2016, just a few months back, with a patient family engagement strategy. And within that strategy were criteria for patient family engagement. That strategy has been included or builds upon the efforts that they have made in the projects that I mentioned earlier, like Transforming Clinical Practice Initiative, the hospital HIN work, which used to be the HEN work, or Partnership for Patients. So within, for example, Partnership for Patients, there were 5 patient family engagement metrics to be reported on. 2 were connected to the clinical interaction, and then 3 were connected to advisory efforts. So things like, do you have a designated person in your organization overseeing patient family engagement activities? Do you have a patient family advisory council or partnership council? And do you have a patient and family advisor serving on your board? So the metrics came out first, and I think the strategy, along with the framework, builds toward the cultural shift that needs to occur in organizations in order to sustain those individual programs or metrics. Does that sort of answer your question? Or Michelle, if you wanted to jump in with any other.
No, I think you covered it. I think one of the points that the group made in terms of alignment is we again have some of these standards and requirements being handed down, and that CMS is just one player, right? One payer that hospitals, health systems, and clinicians sort of answer to in their work, and that's where the alignment piece came in as well, because there are other standards such as the patient-centered medical homes and requirements to be designated a patient-centered medical home and what that looks like, the CAP surveys and the patient experience measurement work. A lot of these activities are really aiming at getting toward a more patient and family engaged care and culture. And again, sort of, although they're driving in the same direction, sometimes again add to a feeling in delivery organizations of what should we be focusing on,
right?
And sort of answering to many different masters in a way, in terms of the activities they should be doing to advance the work. So again, it just highlights the sort of opportunity for broader alignment.
Exactly.
Great, thank you both. And then back to the framework, Joan Maxwell has a question or statement, and it actually goes back to your first question here, Michelle. She would love to know if anyone has used this information to inspire their hospitals, and if so, how did they do it? She spoke to a quality and patient safety subgroup on their board this week and briefly shared about it, sent the document out to all the members, and would like advice on what those next steps would be in sharing the framework.
Wow. Well, Joan, I'm so impressed that you are moving this forward at John Muir. That's fantastic. I think, to be honest, I think it hasn't been in the environment so long that we have maybe some of those answers. I don't know. Michelle, do you have more insight?
Yeah, I don't think what I would love to do is, Joan, get feedback on what you're hearing from them in terms of, I understand, wanting to move it forward. My initial thinking would be sort of based on the circumstances of the hospital itself, where you think there might be areas that are ripe for getting started in the work, whether that's doing, kind of take a look through the tools presented in the paper and some of the resources, thinking about maybe it's an organizational self-assessment. Let's start with running through an organizational self-assessment to see where we are as a group. And then that might help spur discussion around where there may be an area to begin the work. If there's not, if you don't, I'm sure the work's beginning, you're there and you're present. There's been work done at your organization, but a self-assessment may help, get the conversation started about areas that may be ripe for action. I think also working in health systems, it's important to identify champions. If you noticed a member who of the panel that was very excited or motivated by the framework, you might want to link up with them, partner with them, and think about sort of strategies or who you might approach to begin some work or a potential project. And what I'd really love, what would be incredibly helpful to us and of service to the broader field, is what's the kind of information that the members are looking for or need when they're asking you questions? What are their questions? Is it we don't have time? Is it there? What are the messages we can convey in an easy to digest way that might help kind of sell it in a way and help really help those of you working in the hospitals and health systems that are already really committed to the work. How can we best facilitate getting this baked in to your systems, and what kind of materials might we provide that might boil down this information with some of the key messages? We'd love to hear back as you have some of those conversations. But Libby's right, it's fairly new. in the field, having just been released on January 31st. So we're looking forward to hearing back from the field as folks begin presenting it within their systems.
I think that's a great suggestion. And Joan, another thing you might think about is looking at the strategic goals of the organization as they are now, and tying into kind of where an engaged culture would help support meeting some of those broader strategic goals as well. So if there's some connections there that can be made, that might be another way to sort of move it forward. And then I would just reiterate Joan, I know that you're going to be working on this, so I would encourage you to join that Patient Family Advisor Leadership Network and share your, as Michelle was saying, share your experiences as you move this forward. But I think that's a great avenue for doing that.
Awesome. I really appreciate those suggestions, and I will definitely keep you updated on my progress. I feel like this tool, what it does is kind of give credibility to the push that, I'm trying to kind of nudge everybody out of what I would say might be a little bit of complacency, like, okay, we did that, we're done, into we just started. And one of the things that I think did resonate was, in addition to talking about this, I also mentioned at the conference, Libby, hearing Stanford Medical Center talk about having 100 patient family council members and how integrated it is, and that really they don't make decisions without the voice of the patient or family member, and just kind of inspiring people with stories of places that have successfully kind of made that transition and how they did it and how long it took and what that looked like. So that seemed to get their attention as well.
Thanks,
Great.
Joan.
Well, that's reaffirming that the efforts that are being made on more of the national level with policies and the efforts, that those are tying and supporting the work you're doing at your organization. That's really great to hear.
Yeah, it is. And this is Michelle. I think one thing I also wanted to build on is that I think for clinical and executive leadership in health systems, I think one of the key ways we tried to organize the framework, and we kind of dig into that in the paper, is to really start with the outcomes that we're all trying to achieve. And we started there. And what we do is really map how these elements of driving culture change really ultimately lead to these outcomes. And those outcomes are the quadruple aim. It's better care, it's better culture, it's lower costs. And so I think one of the key things in terms of when you're speaking with healthcare leadership is they're trying to achieve these goals, and this is a way to do that. This isn't something that's an add-on or a separate activity. This is central to achieving the goals, and we have evidence. We have evidence to show how this work drives toward those goals that are so critical, not only to the culture of your healthcare and the quality of your care, but in, frankly, the bottom line now. And that can be a compelling way to present it to leadership audiences. It's not only a moral imperative, it's becoming a business imperative as well.
Right. No, that's awesome. And the other thing that I will say, I definitely saw a positive response was when I mentioned how it benefited the staff in terms of the morale and the more compassionate care, and that, I think, really was something they responded to. So there were a lot of good things that I used that I think had a positive response.
Yeah, I'm really glad you mentioned that, because that was really one of the fundamental, considerations when we talk about, improved culture in the system. That's not only the culture for folks receiving care, but also the people working in the system, that the staff and clinicians are key to driving the culture, but also they live within that culture and work within that culture. And you can't truly have patient and family engaged care with a staff that is demoralized, and disengaged. And that really patient and family engaged care is a way to increase joy in practice and satisfaction among staff as well. And that also, I think, I'm glad you mentioned that, because that's a really, really important point.
Yeah. Okay, great. Thank you for the
Great.
excellent suggestions. Really appreciate it.
Thank you. And thank you so much for the work you're doing.
Yes. Thank you,
Absolutely.
Joan. And it looks like we are right at time. I would just like to thank Michelle from the National Academy of Medicine, Libby, for your presentation today. I have their contact information up there. If there were any other questions for either of them, please feel free to contact them. There's also some great resources and information in the chat box if you would like to quickly browse and jot some of those ideas down. But thank you everyone for joining us. Also, if you have any questions for me, there's my email address. And then I also wanted to refer you all to the PFCC Partners Public Resources page, where you can find the guiding framework posted there. It was also sent out to everyone this morning, but if you didn't get it, you can find it on our website as well. And then finally, to wrap up, I just wanted to let everyone know we have an upcoming Champions Forum for PFCC Partners members on April 18th, where we will be talking about connecting the dots of patient and family-centered care, talking about all of the organizations who are working with other organizations, and connecting the dots for all of you. And then join us next month, same time, same place, for our April workshop, where we will have some representatives from the Conversation Project share their great work with you as well. So thank you, everyone, and we look forward to talking to you all soon.
Thank you.
Bye, everybody.
Thank
Thanks
you.
so much.
Thank you. Bye.